Well, with the new data that we have, I believe that it's clear that in order to improve the risk-benefit in terms of people who take drugs that could damage the GI tract, for example, aspirin or other antithrombotics, in order to improve the risk-benefit, it's clear that we will need to prescribe more gastroprotectants, for example, PPI. So then my belief is that today this is very clear, and the guidelines in the recommendation of using antithrombotic drugs probably will recommend the use of PPI, or at least drugs that protect the GI tract in those patients who are at increased risk, which essentially are those who are older than 65, 70, and those who have a previous ulcer history, or those who have quite a good number of concomitant medication that can increase the risk. Well, it's true that many patients have or are taking a lot of different medications. This is going to be difficult to reduce in the future because today, at least, people have different comorbidities, and these comorbidities need to be treated with different drugs. And if for any chance one patient is taking drugs that could damage the GI tract, then they will need a PPI, for example. And the recommendation is that they will need to take the PPI as far as they are taking drugs that can damage the GI tract. So then I don't see any way of reducing the long-term treatment with PPI. Well, having a polypill that could just control different diseases and or prevent diseases in the future, that will be great. But I don't see that close, I will say, in time, because probably we will need much more information to know which drugs should be included in the polypill, and also the dose. And with the new research, we are having new data that sometimes is changing what we need to take and the dose we need to take. So then I don't see that polypill close in time.